Good morning. Well, the standard of care for rectal cancer is still major surgery, as if we follow the NCC guidelines for early stages, direct surgery, and for advanced stage after a preoperative chemo radio treatment. And these are the guidelines of March of this year. But of course, this standard of care have an important impact on quality of life, and multimodality treatment with radiotherapy, chemotherapy, and surgery, of course, are important, have an important impact on quality of life, and surgery still have a rate of some rate of complication, rectal surgery, and also a small death. So try to reduce the invasiveness and the dimension of the tumor is the aim of chemotherapy, of radiotherapy, and also of surgery. The multimodality treatment can reach important results, and we have to keep in mind that from 15 to 30% of patients can reach a pathologic complete response after a chemo-radiotherapeutic treatment. The patient with a good response after neoadjuvant treatment have better survival rates. And this is an evaluation of 8 randomized controlled trials and meta-analysis, and we can see that after a total mesorectal excision, the group of patients with good response have better survival rate. So maybe total mesorectal excision in a pathologic complete response is an overtreatment, and so we have to explore alternative, less invasive treatments for these patients. And this treatment can be a local excision, like biopsy, to evaluate the treatment, and maybe in some selected patient, a non-operative approach. Local excision in T2 and T3 cancer in literature, we do not have a lot of studies. So this is a review of retrospective and prospective analysis of not a high level of evidence, but what we can see is that in good response and good responders after chemoradiotherapy treatment, we have a very low rate of local recurrences. In patient downstage to T0, 0% of local recurrences. In patient understage to T1, 2% of local recurrences. So these studies have been performed in patients selected because refused the major surgery or were unfit for major surgery. We have an Italian randomized controlled trial of total mesorectal excision versus transanal endoscopic microsurgery in a very selected group of patients, and no differences were present in disease-free survival, and the better short-term results were in the group of TEM. And again, the worse results were present in poorer responders. Good responders had better prognosis, of course. But a local excision is present until 20 years, but did not receive a widespread diffusion, maybe because the initial costs were high and maybe the learning curve is steep. Today, we have some new devices maybe that can help in perform local excision surgery easier, and with the normal laparoscopic instrument like the single port devices utilized in endorectal surgery, or of course robotic transanal surgery that can have some advantages versus traditional transanal surgery, in particular in easy suturing, intraluminal suturing, and a magnified view. The problem is in patients with good response, the assessment of response, and in particular the assessment of lymph nodal status. This is the main question. But we have to keep in mind then that when a preoperative treatment downstage the tumor, the downstaging is extended also to lymph nodes. And in patient downstage to YPT0 or T1 stage, the percentage of probable metastasis is range from 2 to 4%, so these patients have a favorable outcome. So in order to optimize our tumor response, to increase the number of good responders. We have to improve, of course, our radiotherapy, and now we have a focused good radiotherapy, and maybe to lengthen the distance of the treatment or of the evaluation after the end of radiotherapy. Prolong the distance, we have better effect of radiotherapy. We evaluate the better effect. The step forward can be after a good response to chemoradiation treatment, the possibility to avoid any kind of surgery. And this is the strategy adopted by a Brazilian surgeon, Angelita Bragama, and this is the protocol of the wait-and-see procedure after the chemoradiation treatment, an evaluation, an assessment of the patient with a lot of examination, and when is possible to see a clinical complete response, then the patient are enrolled in a wait-and-see protocol, and a follow-up, intense follow-up is done with a visit every 1-2 months for 1 or 2 years. Is really important to adopt this protocol to evaluate the clinical complete response, and today we can have the help of some interesting imaging like diffusion MRI. With diffusion MRI we can increase the specificity of more than 90%, or with the evaluation of PET-CT in a period longer than 8 weeks after the treatment, we can have a better accuracy in our clinical response evaluation. The result of this series of Dr. Abragama are really interesting. In 173 patients, 67 patients were received a complete clinical response, where these are the results, as you can see, after the follow-up. 8 patients out of 67 developed a recurrence and then went to surgery, but in 59 patients out of 173, so in 34% of patients did not receive any major surgery, and in a mean follow-up of 47 months we see these incredible results of overall survival and disease-free survival rates. So, to summarize, the literature is poor. We have small, serious, heterogeneous patients, so organ preservation is something that is worth investigating, and there are some ongoing multi-center studying to evaluate the organ preservation strategy. In our institute, the European Institute of Oncology, we are managing a protocol of evaluation of local excision after neoadjuvant radiochemotherapy in a patient with clinical T3N0 or T2N1 stage. We perform a first reassessment at 8 weeks. If bad responders, then the patient go to major surgery. If good responders, we perform a second assessment at 12 weeks. And then if it's confirmed a good response, we perform a local excision, and if local excision confirms the good response, only follow up. If bad response, major surgery. So to answer the question, how long will the surgery be relevant for? Of course, the surgeon must be the leader and the coordinator of a multidisciplinary team with endoscopists, radiologists, oncologists, radiotherapists, nuclear physician. To evaluate the patient with rectal cancer, must be the coordinator of the follow-up of this patient, because this can be patient that can go to surgery in every time of follow-up, and must be the knowledge. Okay, I'm going to finish. Must be the knowledge of all the technique, also not only of total mesorectal excision, of minimal invasive total mesorectal excision, but also to have the knowledge of endorectal surgery. So in this case, the time the surgeon will be relevant for very, very long time, and we have to keep in mind that a complete pathologic response is present in 15 to 30% of patients, but in the other patient, surgery is the elective treatment. Thank you for your attention.
Thank you very much.